Hi everyone, I am Dr. Suraya, founder of Neurobalance Academy, a center for personal and professional excellence. In this channel, we explore tips, methods, and ways to achieve growth and improve well-being. Today's topic is endometriosis. Many women experience cramps, back pain, lower body pain, sickness during their monthly cycles. Women suffering with endometriosis experience chronic, severe pelvic pain, facing difficulty with their everyday lives. They can't go to work for 1 or 2 days per month. They can't work from home either. This debilitating condition affects their personal and professional lives. It causes emotional distress and in severe cases may contribute towards depression. I have been suffering from endometriosis for the past 25 years. Only diagnosed 5 years ago, back in 2015. When I was living in Manchester, I went to the A&E many times with severe pelvic pain during the period of 2006 to 2012, but only came back with more paracetamol. At that time, they couldn't diagnose it or offered me with management plan. Since this condition affects the work lives of professional women, and this channel is all about personal and professional growth and well-being, I have invited Dr. Martin Quinn, a gynecologist and an endometriosis expert. He will share with you his 20 years of research experience in endometriosis. This will shed some light on the traditional view and the real cause of endometriosis. In the next video, we will discuss about the management plan and measures. Before I hand over to him, if you have not subscribed to the channel yet, please subscribe now and hit the notification button to be notified every time I upload a new video. This can change your life. We share life-changing contents. Let's go to Dr. Martin Quinn.
Hi, my name's Martin Quinn. I'm a retired obstetrician and gynecologist. This is a short video presentation of endometriosis, a new understanding of endometriosis that supplants the traditional view of endometriosis that doesn't improve the situation for many women. In this new understanding of the condition, you may be able to understand a lot better why you are as you are and why your symptoms don't improve with treatment. This work's been done over the past 20 years as a research project in both the UK and in China. And the work's been done in 3 tertiary centers in Hangzhou, Wenzhou, and Shanghai, and with different groups of Chinese physicians and students who've contributed in no small measure to this particular view of the condition. This is the present unit in Shanghai that I work in, major tertiary center, one of the leading units in China, and it has a full range of clinical services with some very, very capable clinicians and researchers. And you'll notice that I've entitled the presentation Chronic Pelvic Pain with or Without Endometriosis, because it's most women's experience of the condition that you present with chronic pelvic pain, which creeps up on you for one reason or another, and eventually drives you to go and see your doctor and then get referred to a consultant gynecologist, often after a delay of significant number of years. But it's there that you get the diagnosis of endometriosis. You go with chronic pelvic pain, they tell you you've got endometriosis, and things go on from there. What I want to do in this presentation is to help you understand what the source of this pain is and why the endometriosis part of the title is a little bit of misleading. It's a bit of a red herring, but we'll see that appear as we go along. So by the end of this talk, you'll understand the causes of chronic pelvic pain with or without endometriosis. And in doing so, you'll be able to understand many of the reasons for many of the traditional obstetric and gynecological syndromes that we've always talked about, but have never understood the cause of. And in doing this, you'll be able also to discern a new view of many chronic diseases which emerge as a condition of or injuries to an important part of your nervous system with which you may not be so familiar. So we'll get started and see how we get on. Here's an important image today, and this is a laparoscopic view of a female pelvis. This is the uterus, this is an ovary, the right ovary, the left ovary, fallopian tube, or the fallopian tube. And to get this view, what a gynecologist does is put a telescope in through your tummy button, and with this powerful telescope gives you a very clear view of all the pelvic organs and the pelvic surfaces. This is what it looks like in the operating theatre. There'll be a full team of people available, particularly if you're doing surgical procedures through the laparoscope. But this is what a normal pelvis looks like. And for this condition, for this presentation, what I want you to see particularly is the two uterosacral ligaments. Okay, now this is a little bit technical, but it's important because it's the key to understanding this condition. What your uterosacral ligaments are the two ligaments running from your sacrum, the bone that you sit on, down towards the uterus. And the important part of them is that they convey the nerve supply of the uterus and the fallopian tube through here into the neck of the uterus, and then down each fallopian tube like this and like this. I've also labeled here something called the Cardinal Ligament, which is a smaller version of the same sort of suspensory system. And that too, there's some nerves that run to the uterus and the fallopian tubes. And in between, you'll see, as we go on in this talk, that there's a huge swathe of nerves which are not visible during laparoscopy, but which are very important in terms of time of pain and how it presents. So what we'll do is just show you now what endometriosis looks like. I've put the normal view up here on the left, and these are 4 different patients with endometriosis. And what I want you to look at is you can see the uterus here, 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 and here. And each time I'm going to show you A, B, C, and D in this order. So the panels are going to be top left, top right, bottom left, and bottom right as we go along. And here in the top left, here's the uterus, here's the fallopian tube, and ovary behind it. Here's the fallopian tube, ovary here, and there's the 2 uterosacral ligaments that I talked to you about. Here's some deposits of endometriosis, and it's the brown stuff, 1, 2, 3, 4, like this. And you can see there's a red inflammatory reaction around each blob of endometriosis, okay? And it's alleged that this is what causes all this pain and infertility in a woman. And these 4 small deposits would amount to what they call grade 1 endometriosis. In panel B, you see the same sort of thing, just shows the variety of endometriosis that you can find. Here's a red deposit, the uterus is here. This is the right uterosacral ligament. This is the left uterosacral ligament. Here's a red deposit, a brown deposit, and a blue deposit, all endometriosis of one description or another. Here again in panel C, the uterus is at the top. Here's one uterosacral ligament, here's the other uterosacral ligament, some deposits of endometriosis up here, along with degrees of inflammation of the peritoneal surfaces like this, okay? Finally, slide D, what you can see here is two large thickened uterosacral ligaments like this, all clothed in ectopic endometrium. This is very serious. This is stage 4 endometriosis. And this is a really terrible set of circumstances for this woman. We'll come to discuss this one in much more detail as we go on later in the talk. So all I want to do is show you in this slide the variety of different appearances of endometriosis. This is just a small sample. There's all sorts of things, but I want to emphasize to you the predilection that the condition has for a woman's uterosacral ligaments, and that'll become significant in due course. Now, this endometriosis was largely discovered by this man, John Sampson. He was a doctor working in New York, and what he noticed in an initial series of 21 patients in 1921 was he found these deposits of ectopic endometrium all over a woman's pelvis, and he put forward what's become the traditional view of endometriosis, where there is what is called retrograde menstruation. In normal menstruation, the endometrial debris is passed out of the body through the cervix and through the vagina along the red arrow. But in retrograde menstruation, some part of the menstrual loss passes up the fallopian tubes like this and out onto the peritoneal surfaces, the surfaces of the pelvis, along the blue arrows. And it happens in both fallopian tubes. And Sampson was quite clear that the endometrium passes through the fallopian tubes to attach two different surfaces in the female pelvis to form this endometriosis. And there is where they cause chronic pelvic pain. Now, there's a problem with this because there's no explanation here for why the endometrial flow passes up the fallopian tubes instead of its normal passage out out of the body from the vagina. There's no reason given why it attaches as it does often to the uterosacral ligaments. And finally, there's no explanation of why such ectopic endometrium or endometriosis, deposits of endometrium, might cause pain. Okay, if you really want to disturb an endometriosis expert, you ask them, what's the evidence that ectopic endometrium causes pain? Because in the 100 years since Sampson described it to begin with, there's been no satisfactory answer to that question, not in this traditional view. Now, this traditional view doesn't stand up to very much examination, because you can take out everything in a woman's pelvis, the uterus, the fallopian tubes, the ovaries, every speck of endometrium, and the woman still has chronic pelvic pain. That is unfortunately an outcome for many women with this condition, but it is certainly not satisfactorily explained by this traditional view of endometriosis. Secondly, you can see women, particularly in China, where I've been working recently, where you can have 1,000 grams, you can have or not a kilo, but half a kilo to a kilo of endometrium in a woman's pelvis, and it's absolutely painless, absolutely no pain at all. In fact, they complain that the large uterus is pressing on their bladder or pressing on their rectum, and that's the reason why they want to have their uterus removed. And so you see it like this. If I move on to this slide, here's two large uteri. These are both Chinese in origin. We don't see it quite so often like this in the UK or the US. On the top left, you see this large uterus with blood from almost every cut surface, bleeding from every cut surface of this specimen. And here's another one, looks like a cheddar cheese. This one weighs something over 1 kilogram. And neither of these women, despite having up to 1 kilo of ectopic endometrium in their pelvis, had any problems with pain. Absolutely none. So the question was, how could they accommodate 1 kilo of endometriosis like this in their pelvis and feel absolutely no pain. But even when it's bleeding from every surface, every part of its cut surface, every month when they have their periods, still no pain. We'll get to that in a moment. Now, to get to this new explanation, you have to understand a little bit about what's called the autonomic nervous system. Now, I appreciate this is a little bit new, so I'm going to take this very slowly for you. Normally in the body, you have a nervous system that you can control your arms, your legs. It's all under voluntary control, and movement is the controlled by what we call the somatic nervous system. But apart from that, you have another one called the autonomic nervous system, or you can call it the automatic nervous system if you like. And what that is this picture on the left here, where the nerves run down from your spinal cord into your body, and they suspend your heart. Here they are supplied to all your abdomen and abdominal organs, and then also in your pelvis. And there are three large plexi here. This is the one behind the heart. This is the one behind the pancreas here. And this is the one in your pelvis. You have one on either side of your pelvis. And this system supplies all your organs in the body. You're unaware of what it's doing, but basically it's regulating all your blood vessels and all your organs to ensure that they coincide and act together in a coordinated fashion to maintain your health and well-being. It's all run from your midbrain up here, and it's a very important system. It's divided into two parts, your sympathetic and parasympathetic divisions, which you've probably heard of. The sympathetic division runs in the sympathetic chain, which is this thing here. This is the spinal cord here. This is the sympathetic chain. Don't worry too much about the details, but this one runs along the head of your ribs. And it's supplied to you, it passes out as different branches to supply all these organs. The blue part, the parasympathetic nerve fibers, usually pass through this nerve, the vagus nerve, number 10, and supply all your organs like this. And the two bunches of fibers often coalesce as they pass into the organ system, organ that they supply. Now, the problem with this autonomic nervous system is that we lost it. Medicine lost it. And when I say that, I don't say that pejoratively or in any other way, but that we had a little accident. And I'm going to explain that to you in detail in a moment. But all you have to do at this moment is understand that you have this secondary nervous system which supplies all those functions of your body which are vital to keep it going. And you can call it the automatic or autonomic nervous system. This is a little gruesome. I'm sorry to put this slide up for you at this stage, but it shows you why medicine's lost it, because this is a semi-section of the pelvis. Here's the sacrum, here's the pubis. This is the uterus, cervix, this is the vagina, here's the bladder, here's the urethra, and here's the rectum. But between the sacrum and the pubis, there's this huge mass of neurological tissue, and this is the pelvic plexus. Okay, now you'd think that every doctor in the world had seen this picture, because they're so gross, these nerves. They're huge, they're easy to see, and they all run from the sacrum running down towards the junction of the uterus and the vagina. And they're very vulnerable to injury down here, but we'll come to that in a moment. Now, why, if I put this up in front of 100 doctors, you just get blank faces and open mouths, because nobody has ever seen this particular picture in contemporary medicine. And that's because when we were taught on specimens like this. And this is what we were taught our undergraduate anatomy on. This is a specimen that's been prepared in formalin and embalmed in formalin. This one has been prepared and embalmed in alcohol. and you can see that all the autonomic nerves are carefully preserved. In this one, or despite this being one of the best dissections I've ever seen, the whole of these nerves are probably represented by number 33 here, this labeled stringy little bit of nerve here, maybe 32 and number 8 as well. But it's a very poor representation of the full morphology of these nerves, okay? And this is simply because formalin destroys the autonomic nerve. So in all the generations of doctors since 1945, over the last 75 years, very, very few doctors have seen the full morphology of this nerve plexus, or the cardiac nerve plexus, or the celiac nerve plexus. And it transpires that these three structures may be very, very important in terms of our overall susceptibility to disease. So if they all converge like this onto the junction of the uterus and the vagina, they are vulnerable to injury, and you can guess immediately what are the sources of injury to this nerve plexus. First of all, if you put a baby's head in here and deliver a baby down the birth canal down here, that any problems during the first labors particularly will have the capacity to injure these nerves, particularly if there's any traction applied, the baby's too big, the labor's drawn out, there's too much pushing in the second stage of labor, then all of those things will contribute to injuries to this nerve plexus. Second, if you've had any sorts of pelvic surgery, particularly minor pelvic surgery to do with evacuation of the uterus, where you have to apply an instrument to the cervix, which is here, and if you apply traction through the vagina to this cervix, then you can see that the nerves are also in the firing line. Okay, so different types of gynecological surgery can injure this nerve plexus. And then finally, the third thing that will injure the nerve plexus is not so intuitive, but it's important because it's very common. And that is straining on the toilet. When you go to the toilet, if you have any difficulty with constipation and you have to strain on the toilet, that can seriously injure these nerves, okay? And 20 to 30% of the population, many Western urban populations, will have difficulty with straining on the toilet. Not so common in Shanghai, not so common in Wenzhou, but it's appearing in those cities in China because the changes in the diet that have taken place over the last 20 or 30 years. McDonald's, KFC, Starbucks have all appeared. Chinese diets have deteriorated, and they're beginning to suffer from different types of constipation, which we'll come back to in a moment. Now, just to remind you, these are just some pictures of the abnormal uterosacral ligaments, because I told you that the nerves run through these uterosacral ligaments to reach the uterus. Now, I'm just going to show you the two slides at the bottom in figure C and figure D are women who've been injured in childbirth. In this one, figure C, here's the uterus. Here's the fallopian tube, will be on this side here. And here you can see what's left of the uterosacral ligaments. In this particular labor, this poor woman almost ruptured the back wall of her uterus and then has almost completely avulsed her left uterosacral ligament. Now, if she does that, she also loses the nerve supply to the uterus and the fallopian tube on the same side. And the same to some degree, because she's lost the body of the ligament in this particular specimen, in this particular laparoscopy, she can lose the nerves here to the uterus and the fallopian tube on this side. Same in this one. This lady had this first patient, she had a forceps delivery. This woman had a similar delivery, but with a large baby, 4.24 kilos. And you can see the right uterosacral ligament is intact, so the nerve supply is still there. But on the left side, it's been completely replaced by large veins, venous channels, if you like, where the ligament's been pulled off, and she's lost the nerve supply to this side of her uterus and the fallopian tube. In this specimen, what we can see here is that the uterosacral ligaments have become much thinner than normal. They've been thinned out, and the reason for that in this circumstance is that this woman's had drugs called mifepristone and misoprostol to make the uterus contract to have a miscarriage or a termination of pregnancy. And in fact, this lady's over-contracted her uterus because of a complication of the misoprostol, prescription of misoprostol, where the misoprostol gets given a little bit too frequently, or she has an idiosyncratic reaction to it. And you get this very, very dramatic thinning of the uterosacral ligaments. And if you take a section of these, the nerve supply inside is completely obliterated. So again, we lose the nerve supply to the uterus and the fallopian tubes, and in time it will become very painful. Finally, this is the picture that you've seen before. This is the stage 4 endometriosis, and what you can see here is these very large, thickened uterosacral ligaments covered in endometriosis. And what's happened here is this is a woman who's strained on the toilet because she suffered from constipation. And what happens is she's injured her nerve supply which runs through the ligaments, as we explained already. And you'll see different changes in the uterus associated with all these different injuries. So different changes to the nerve supply of the uterus, which I'm going to show you now. Now, you can only see these changes if you look in this part of the uterus, and technically it's called the neck or the isthmus of the uterus. Okay, it's no good looking here in the body of the uterus or here at the top of the uterus. You have to look in a small block of tissue, maybe 5 to 10 millimeters across, in the neck of the uterus. And it's only there that you'll see these changes. And what you see is this sort of appearance. Now, the brown bits are nerves, and in these B, C, and D, they are injured nerves, but we'll get to those in a minute because I just want to show you what a normal uterus looks like. Here's the brown nerve tissue between the endometrium. This is the lining of the womb and the muscle of the womb. Okay, and this is very important nerve plexus, which keeps the two separate. And these are some endometrial glands which are cross-staining for this particular stain. And this is the normal arrangement. The myometrium, the muscle of the uterus, is very sparsely innervated, and it's important for different reasons, but we'll come back to those in due course. Now, in those circumstances that I've just shown you, where the nerves run into this part of the uterus, into the isthmus of the uterus, when you take this section, what you find is the nerves are very severely injured. These are all abnormal nerve fibers, and these are the reason for all the pain and the suffering in women with chronic pelvic pain, whether they've got endometriosis outside in the pelvis or not. Okay, and here you see large numbers of abnormal nerves throughout this woman's myometrium, the muscle of the womb, and they're all over the place. They're running in all different directions. They obey no rules. They don't divide tissues like in the normal situation. They run through everything, and they'll run into the endometrium, running to the muscle of the womb as well. And if you touch them, they cause exquisite pain. And this is the sort of appearance that you see after a woman's had a difficult labor, or if she's had surgery to her uterus, that sort of thing, then this is the appearance that you see. It's the same that you see here. This is a picture in panel C where we're looking at a nerve bundle. And here the nerve bundle's been injured in such a way that it's been torn apart. Nerves don't like to be stretched. They like to be left in their normal position, but if you stretch them, then they'll fray and break like this. And when you see this sort of appearance, it's called sprouting of a nerve bundle. This is absolutely typical of a traumatic injury. So this is either a difficult first labor that contributes to this, or some sort of gynecological surgery or gynecological drug treatment that we've already discussed. And that's what you see in these particular circumstances, absolutely typical of a traumatic injury. Finally, and this is a specific form, this is a slightly different appearance, where you have a blood vessel here, the blue thing is a blood vessel all across here, and the wall of the blood vessel is thickened. It's difficult for you to tell that, but you can see that the lumen here, the channel for the blood, is very much reduced to normal. Normally it would be as large as, almost as large as the vessel wall itself. The wall will be relatively thin, but here it's become narrowed, and it's become narrowed because the nerve supply to this blood vessel has been injured. Instead of seeing a single nerve supplying this blood vessel, you've got hundreds of nerves around this blood vessel, and this is very typical of the effects of straining on the toilet, or in fact pushing in the second stage of labor. If you're pushing for too long in the second stage of labor, very similar mechanism of injury, then you'll get this sort of appearance where there's large numbers of injured nerves running around the outside of the blood vessel. And that's very important, because as the blood flow increases just before your period, then these nerves will get stretched, cause a great deal of pain and suffering, and it becomes very, very difficult for the woman until she starts to menstruate, when the blood flow reduces and her pain improves. So these are very, very typical appearances of injured nerves, and it's injured nerves that usually cause pain in the body. Wherever you have injured nerves, if you have different stimuli to them, I've indicated that increasing blood flow is one, then you can cause a great deal of pain and discomfort, particularly at different times of the month, as a result of these nerves being triggered by the increase in blood flow, by the increasing diameter of the blood vessels, and causing a great deal of pain. So here's a better mechanism. Instead of just a few deposits of endometriosis around the pelvis, here you've got large numbers of aberrant injured nerves sitting at a particular point in a woman's pelvis, and it can involve the cervix, it can involve the vagina as well in advanced circumstances. But here you have real evidence of injured nerves and the source of pain in some circumstances. We'll come back to that in a moment. And instead of, this is what typically goes on, instead of treating those injured nerves, this is a woman who's had an operation for endometriosis and for pelvic pain. Here you see a preoperative picture in the top left. Here's a picture on the bottom right, and you can see this is preoperative, this is postoperative. You can tell that a robot's been used because one of the ports is called a Da Vinci port, so that's usually the Da Vinci robot that's in evidence here. And here you can see what was a normal, well, not a normal, markedly abnormal uterus and fallopian tubes has been operated on, and you can see all this terrible scarring and charring of tissue all the way through. In fact, we say that the ectopic endometrium is not the source of the pain. We think that the injured nerves are much more likely to be the source of pain than this very small deposits of ectopic endometrium. Anyway, this is just an exemplary picture of how things are pre and post surgery, where we call this excisional or ablative surgery, and you can see some of the consequences of that. So we have accumulating evidence of an injury to pelvic autonomic nerves. We first published the evidence for this back in 2005. Different groups now have identified these same injured and abnormal pelvic nerves. And it's a very very serious injury that's occurred to many women as a consequence of difficult first labors, straining on the toilet, or different patterns of gynecological surgery. But aside from that, you have a large number. In the last 10 years, we've found a lot more about what some of the consequences and corollaries of endometriosis, or chronic pelvic pain with or without endometriosis, as I prefer to call it. And that is that a lot of women who've got this condition will also have suboptimal reproductive outcomes. In other words, they'll have small babies that are born too early. They'll have complications associated with high blood pressure and things like that, or they'll have more miscarriages than a normal group of women. It's certainly a very, very poor prognosis for many women who have these who have this endometriosis or chronic pelvic pain. If you have this underlying nerve injury, then that seems to prejudice you to these adverse reproductive outcomes. Also, a lot of women who've got this chronic pelvic pain with or without endometriosis have a lot of other symptoms. They have headaches, migraines, feel sick, feel tired, but different times of the month. They'll have ringing in the ears sometimes, all sorts of extra pelvic autonomic symptoms, which are usually are, in this view of the condition, are the consequence of what we call visceral reflexes. Now, all that means is that the nerves, the autonomic nervous system, is connected from one part of itself to another. So you have connections between the uterus and the kidneys, between the heart and the kidneys, between the liver and the kidneys, from the uterus to other parts of the system. And if you have a part of it that's injured, then it tends to misfire. And when it gets stimulated, you get these other adverse outcomes, which are typically things that are very distressing and uncomfortable, but very difficult to put a precise finger on their source. So it's these extra pelvic symptoms that arise from reflexes, which have become much more understandable, let's put it like that, in more recent years. Finally, you can have inflammatory bowel disease. By that we mean Crohn's disease, ulcerative colitis, and things like that, simply because the nerves that supply the uterus and fallopian tubes, all similar nerves, supply the small and large bowel, and they're contiguous. In other words, they're in adjacent segments. We call the nerve supply to the uterus and fallopian tubes come from the 10th, 11th, and 12th thoracic segments, whereas the nerve supply to the small and large bowel come from the 8th and the 9th thoracic segments. So if you injure your uterus, you also tend to injure your bowel as well. And similarly, you can injure your kidney, and that causes hypertension with some of its complications. And simply, if you have a lot of problems with straining on the loo, straining on the toilet, you seem to be able to generate these autoimmune diseases as well. Autoimmune is a label that's applied to many different conditions in medicine, often which we don't understand at all, but a lot of them are associated with this particular problem. This image here illustrates why we have some of these problems, particularly the problems in the uterus that contribute to adverse reproductive outcomes. If you look at this one carefully, you can see that in the top panel at the left, you can see here's a thickened vessel, which we've known always has been, since 1945, we've known it's been associated with high blood pressure, small babies, all the rest of it. But what people haven't noticed is this layer around the outside of white empty cells like this. And what that indicates is the same position as the brown injured nerve fibers that I'd shown you before. What happens in pregnancy is the uterus gets bigger, that the nerves don't grow with it. They stay in the bottom part of the pelvis, but as the uterus gets bigger, the blood vessels run with these empty cells around them, which indicate the prior neurological injury. And we know that the women that have this appearance often have high blood pressure in pregnancy, small babies, more risk of reproductive loss of one kind or another. And so we think both the obstetric syndromes and these gynecological syndromes are both the consequence of injuries to these autonomic or automatic nerves. The same applies in the kidney and different organs in high blood pressure. This is category number, this is the thing number 4. Here you see a blood vessels in this row here, which is the second row. This is in the kidney. You see that the blood vessel is completely surrounded by injured nerves, and that is an indication that there's been a degree of injury to the to the nerve supply to those blood vessels, and that's the mechanism that we understand as what becomes hypertension, which is such a significant disease that we'll all die of it, of the complications of it, either through heart attacks or strokes or other things that it causes. And women with endometriosis and chronic pelvic pain are much more vulnerable to that than others. So we get to this second view of chronic pelvic pain with or without endometriosis, and you can read it. And it says that endometriosis is much better explained as a consequence of injuries to these automatic or autonomic nerves, which have wide-ranging lifelong clinical consequences and which won't get better with surgery. They don't get better with, we can improve it by reducing the blood flow in a woman's pelvis and by doing other things, but they certainly don't get better with all these big surgical procedures that a lot of women are exposed to. What gets this condition better is the menopause, or an artificial menopause, that we can create through different treatments. And it's that shuts down the blood flow around these nerves and turns off the pain to some degree. The deposits of the endometriosis, or ectopic lining of the womb as it's called, ectopic endometrium, these are largely red herrings to these underlying injuries. So once you understand that we're not dealing with these deposits of endometrium as the source of the problem, but we're dealing with injuries to pelvic nerves, and that's the key difference between the traditional view of the condition and this view of the condition, which is a much more coherent explanation of how a woman's symptoms present. If we look at how we're going to deal with it, first of all, we just deal with it technically. Clearly, it's very important to be able to take the correct history from these women. So it's very important, if you're presenting to a gynecologist with chronic pelvic pain, that the doctor asks you about your bowels, he asks you about your first labors, and he asks you if you have any miscarriages or any sorts of other injuries to your pelvis that would potentially interrupt these nerves. Because it takes 5 years from the injury for your symptoms to develop in order to create the conditions that drive you to go and see a doctor of one description or another. And traditionally, he or she will still look at your pelvis through a telescope, try and differentiate whether there's endometrium or no endometrium. But the more important question is not whether there's this endometriosis is present or not, but what injuries have you sustained in your pelvis? Have you had difficulties in childbirth? Have you had treatment for miscarriage or termination of pregnancy? Have you had troubles with straining on the loo? Or in these circumstances, down at the bottom, these are Chinese pelvis. You can have very major injuries coming from a combination of these different effects. But it means that you may be better off having a radiological examination of your pelvis, like this MRI up on the top, at the top here, rather than be put through all of the difficulty of a laparoscopy under general anesthesia in order for the gynecologist to look at what's largely an irrelevancy, the presence or absence of ectopic endometrium. So you might be better off having an MRI to begin with. And of course, these women often present not just with pain, but also with infertility. And this is just to remind me to mention that, because here you have a normal fallopian tube with all its normal villi and rugae. And here you have 3 women who have absolutely no nerves left in their fallopian tubes. They can't contract properly. They can't deliver the egg to the sperm. And these women are going to be much better served by IVF rather than attempts to try and achieve pregnancy through the normal route. Okay. So the strategies then, after you've dealt with that, you've clearly got to do something about a woman's diet. If she's having problems with a bowel habit, do something to do with, help her to understand what a proper diet is, what a proper bowel habit is. A lot of patients, 1% of women only go to the toilet once a week, 0.1% only go to the toilet once a month. And that's really, really serious in terms of these sorts of injuries. But clearly, unless you ask those questions, and you won't understand what the source of the patient's symptoms are. Then you've got to decide what to do, how you can best help this woman. Conventional gynecology has it that you reduce the blood flow. I agree with that. But conventional gynecology also goes on these big surgical adventures looking to excise or ablate all this ectopic endometrium when it's largely a red herring. What I've done is to put a couple of websites together just to to put some papers there and with some pictures so that you'll see all the pictures I've shown you in this presentation. If you go to www.preeclampsiaexplained.com, has a list of papers, as well as endometriosisexplained.com. And there you'll see rather technical accounts of these sorts of pictures. But the essential fact is that the woman's symptoms are much better explained by the new view of endometriosis, chronic pelvic pain with or without endometriosis. And the traditional view is simply a descriptive account of what Samson saw 100 years ago and what latterly more gynecological surgeons with a laparoscope have seen, but it doesn't explain the woman's symptoms nor the course of her treatment, because it's very, very common that women experience persistent or recurrent pain despite all the best efforts of the gynecological surgeons to excise and ablate all this ectopic endometrium. So I think that's where I'm going to leave it for this first video. We can deal with another, dealing with all the...
I have some questions. Can I ask some questions?
Yes, by all means, Abhi.
Right. Okay. Thank you, Dr. Martin, for a very informative presentation on endometriosis. As an endometriosis sufferer for the past 20 years, I know what I go through, and this channel is all about productivity and well-being. And you know, once a month you lose a couple of working days, you know, for the pain, and then you are not able to work and go to work. So you are losing a lot of time, precious time for endometriosis. So I would like you to go to slide 2. I have a couple of questions that I would like to ask.
Slide 2, yes, I can.
Slide 2, please. Oh, you showed in the slide 2, you showed picture of healthy uterus, and you also showed picture of uterus that had red and brown spots, ectopic endometrial spots. So those spots, have you looked at the composition of those spots and how they are different from a healthy cell?
Yeah. These are all endometrial cells. That means they're all cells from the lining of the womb. If you take these out and biopsy them and put them under a microscope, the definition of endometriosis is that you see the cells that you normally see in the lining of the womb. So in order to make a formal diagnosis of endometriosis, that's what you should be doing. You should be taking a biopsy of these different areas and putting it under the microscope. But that's when you do that, that's what you find. You find the typical appearances of the lining of the womb and not the peritoneal surface that they're sitting on.
So are those cells, like the composition of those cells are similar to the, if those cells were inside the, inside the womb, are the composition same or the composition
same?
Different?
Absolutely same. And they bleed where at the same time as the month as that you normally bleed. So when they swell up in response to the production of the hormone estrogen, and they produce menstrual loss, as it were, and you'll see puddles like in panel A, you see a little puddle of serous fluid, same in panel C. You can see there's been some bleeding, same in panel D, because when the woman has the increased production of estrogen, then that tissue will be shed, and then you'll see this sort of appearance where there's been some bleeding, and that was what was attributed. Some of the pain was attributed to, but that's clearly not the same timing as when most women, as you described, have been, where you have the pain in the run-up to the period rather than during the period. At the time of the period, the pain often gets better, whereas the pain that you're describing gets worse as the estrogen increases the blood flow to your pelvis. These spots swell up and then they're shed when you start to menstruate.
Right. And so why there is a color variation? So we can see the color variation, red and brown. Why there is a color variation?
It's just a question of the contents. Sometimes you see old blood, and that tends to look a little bit more brown. Sometimes it looks a little blue. Sometimes you get some hemosiderin, which is a pigment associated with hemoglobin. You'll see that as well. So they can be very variable, but they're usually found associated with the uterosacral ligaments, the two folds that I was talking about. And you'll see that much of it is around them, because it's them that are injured in a lot of these women.
Thank you. So there is in slide 3, you have pictures of Chinese endometriosis. You showed two. One is 260 gram, another is over a kilo. So if I understood correctly, they are, what are they actually?
This is a different form of endometriosis. It's called adenomyosis in technical terms. But what's happened here is that the lining of the womb, instead of being shed and passed out through it's grown through the muscle walls of the uterus. So it's grown out into the muscle of the uterus and out towards the outer layer of the uterus. And in these two specimens, they weighed 260 and 1160 grams. We collected a series of 34 women with these problems, and all of it was painless, absolutely painless. So you can have these massive amounts of ectopic endometrium or endometriosis stuck in your womb, but no pain at all. So it gives the lie to the idea that the 2 or 3 millimeter deposit that was sitting on your uterosacral tubes, on your uterosacral ligaments, is the reason why you can't go to work for 2 or 3 days a week. It's not that. The problem is to do with inside your womb, and it's where those injured nerves are sat in the neck of your womb, causing you a great deal of difficulty and trouble when your blood flow increases. So this is just an example. There are many examples or many reasons why that traditional view doesn't account for all the presentations of endometriosis, and you have to deal with each on its own merits, because there's lots of different presentations depending on how a woman, where it is, how much of an injury she's had. But the key point is that it's not the deposits of ectopic endometrium, or these women would be in terrible difficulty. But these two women here showed extreme forms of endometriosis or adenomyosis, where the endometrium is bleeding in the top left one, but that doesn't cause any pain. And in the bottom one, you have this huge sort of cheddar cheese, which doesn't cause any pain at all. It just sits there quietly and presses on the adjacent organs. And that's why the women come and have a hysterectomy.
That is quite surprising that you have such a big mass in your pelvic area and you don't have any pain. That is quite surprising to me.
Yeah, well, part of the reason is because you lose that nerve supply between the lining of the womb and the muscle of the womb, that I showed you in one of the microscope slides. I showed you that one in the slide, microscopic slide. It's the one up here on the left. And you can see there's a big nerve plexus between the lining of the womb and the muscle of the womb. If you lose that nerve plexus, then that creates the conditions for the endometrium, the lining of the womb here, to invade the muscle of the womb. And the end result is the pictures that I've been showing you in the two large macroscopic pictures of the uterus. And so that's why, part of the reason why you don't feel so much pain is you've lost some of the nerve supply. But the other reason, the other point about it is that it allows this lining of the womb to invade all the way through. And if you've got so much ectopic endometrium now, it's because it's not in its normal place, growing into the muscle of the womb, you may think that that would cause you pain. And it clearly doesn't for these women. Those women in China, they didn't have that problem. Now, that particular condition is not so common in the US or the UK. It arises for different reasons, which I won't go into now, but it is one particular reason why you get this.
What problem they came to you with? What was their symptoms?
The uterus would press on the bladder or press on the rectum. So they would come with frequency passing urine or having to rush to go to the toilet, or they'd have some degree of constipation. And those two would alert the doctor to do an ultrasound scan and find these large uteri. And that would be the reason why they wanted to have a hysterectomy, or felt that a hysterectomy would be a better
I think a couple of slides, slide 7 or 8, you showed the pictures, 4 pictures again, and then you showed what happens when the nerve is injured. Nerve injury occurs mainly for 2 reasons. One is difficult first labor, and number 2 is straining in the toilet, right? Then, so these are for, I'm guessing that these are for older women. So have you seen girls, 13 to 18 years old girls, they are diagnosed with endometriosis? It would be nice to have a look at their uterus and compare, just for the sake of comparison.
The teenagers, and almost all the teenagers, have serious problems with constipation and straining on the toilet. And they are, to a girl, usually the picture is the same as we see in panel B, which is the one with the big, thick uterosacral ligaments and lots of deposits of endometrium. And that's a very serious situation for them, because it means that they probably had the problem with their bowels for many years. And even though they're presenting very young, that's the typical situation. And of course, they haven't had any babies, they haven't had any miscarriages or anything like that. They just get into trouble with pain in their, either from their first period at their menarche, or first period as we call it, and then, or during their teenage years. And it can cause a great deal of difficulty, sitting examinations and all the rest of it. Just with day-to-day activities, it can cause enormous troubles for those girls. But that's what it usually is, and it's a disaster because it prejudices their reproductive careers. It's going to be very difficult for them to get pregnant, and it causes them considerable problems for the rest of their lives.
Thank you. I have just the last question. I think it's a general question, which is how to heal damaged autonomic nerves.
They don't get better very easily. It's a question of preventing them. We have to prevent these injuries. People have to know, women have to know that they don't want to be exposed to straining on the toilet or difficult first labors or gynecological surgery if they can avoid it. It's far better to keep your autonomic nerves intact, and we'll discuss that in another video because it causes a great deal of many other problems around the body. But you need to prevent these injuries, because once the nerves are out of their sheaths, it's very, very difficult to control them. And what you've got to do is shut down the blood supply to that particular part of the body, if it's at all possible, in order to restrict the damage that these nerves will do in terms of pain to the woman. And that's best done pharmacologically in the first instance, but sometimes you have to do a hysterectomy. Sometimes you have to bring on a premature menopause in order to preserve the woman's health and well-being as far as you can. But it's always a difficult situation. It's always something that has to be managed in the individual's best interests of the woman. But the key thing in this condition, and the key thing in a lot of medicine, is to avoid these injuries to autonomic nerves, because once the nerves are injured, once they're out of their sheaths, they cause a great deal of difficulty all around the body. And we've said that there's, the three big plexi, the cardiac, the celiac, and the pelvic plexi. We're only talking about one aspect of the pelvic plexus here as it runs towards the uterus and the fallopian tubes, but you get the same problems in the bladder, in the bowel, probably in the appendix, probably in all parts of the body. Exactly. And that can cause all sorts of chronic diseases, which, as I say, we can discuss on another day.
Thank you very much, Dr. Martin, and hopefully we will create another video on management, endometriosis management in next week or the week after. And thank you for being our guest today. Thank you very much.
Thank you very much, Sabine. It's been a great pleasure.
Thank you.